Slides are ridiculous. Wow. This is too much.
Good morning.
Wow. You know that I feel that I've met you before. I don't
Okay.
know.
Good morning, everyone.
I have the same feeling.
Good morning.
Where did you work before
Right.
that measure?
Hi, everyone.
For that? No.
It's really good to be here and to see all these familiar faces after so many years, as well as, the new faces. So welcome, everyone. For those who don't know me, my name is Joy Kamunyori. I am a Senior Health Information Systems Advisor with USAID. And I am here today to talk with you about our collaborative learning agenda around our digital health investments related to COVID-19 vaccinations. So just to set the context really quickly before I turn things over to our more interesting panel members. As Dr. Gawande discussed in his comments today, USAID launched the Vision for Action in Digital Health, otherwise known as the Digital Health Vision, in 2020. And the point of this vision document was to apply learnings from the 2014 to 2016 Ebola outbreak in West Africa, which saw the implementation of many digital health systems to deal with the crisis, but most of which are no longer in existence today. So the vision aims to address the challenges of fragmentation and lack of sustainability and interoperability in the digital health investments that we make, and does this by identifying 4 priorities to guide digital health-related USAID planning, procurements, and programs. So the 4 guidelines and priorities which Dr. Gawande also referred to are to assess and support country digital health capacity, national digital health strategies, and national digital health architecture, including, where relevant, through the use of global goods. So 4 years on, 4 years from the Ebola outbreak, not from the digital health vision, the COVID-19 pandemic hit us. And once again, USAID and its partners leapt into action. And as vaccines started to roll out to our partner countries, investments were made in digital systems to help track vaccine supply and coverage. This time, we worked to take a more deliberate and intentional approach, encouraging our partners to keep in mind the principles of the digital health vision as they implement these systems, with an eye to creating sustainable investments that outlast the current emergencies. We want to learn from these investments and to draw out lessons from this implementation experience that can be applied to future disease outbreaks. The COVID-19 Digital Health Collaborative Learning Agenda was formed with this purpose. We are working with 4 of USAID's centrally funded mechanisms to explore how a subset of our COVID-19 digital investments have been structured to advance vaccine management and distribution while also building country resilience to future health shocks. These 4 mechanisms are here today, and we'll hear from them about the country-specific studies that they're undertaking to explore how vaccine delivery-focused investments in country digital technology and data systems have been implemented in line with the principles of the digital health vision. While this work is still ongoing, we think there are still some interesting lessons and themes that have begun to emerge as they undertake their studies. So we will be asking them to speak about those today. So I'll now turn to our panel participants, and I'll ask them to introduce themselves and tell us about the work they'll be discussing with us today. To my immediate left, I have Jessica Shearer from the Momentum Routine Immunization and Equity Project. She is also representing Dr. Godefroy Mpanya from their office in the DRC, who was unfortunately unable to join us today, but we will be seeing a short video from him. Next to Jessica, we have Hassan Mtenga from Digital Square. Next is Stephanie Watson-Grant from the Country Health Information Systems and Data Use Program. And last but certainly not least is Liziam Valladares from Datafy Honduras. So I will now turn over to you all and ask you, Jessica, to go ahead and introduce yourself and describe the work that you'll be discussing with us today.
Thank you so much, Joy. Good morning, everyone. It's great to see everyone here.
And wonderful to be here on behalf of my colleague, Dr. Godet, who wasn't able to make it, as Joy said, but I'm very proud to represent Momentum Routine Immunization Transformation Equity and our DRC country program. So the MRIGHT Award works in 17 countries currently, supporting COVID vaccine introduction and scale up. We also support routine immunization in 4 large countries. So we work on immunization, and as you can imagine, we work on all aspects of immunization. When it comes to our work in DRC, we've been there since before COVID vaccines existed, and so we became involved very early on in the process in terms of planning for COVID vaccine introduction, thinking about the cold chain requirements, the service delivery requirements, demand generation, all aspects of that. And one common theme has been digital health interventions and how we can use appropriate and fit-for-purpose digital tools to help accelerate all aspects of those processes, because this, of course, is a scale and a pace that we've never seen before. There's no playbook for COVID vaccine introduction and scale up, right? So we've been using digital health interventions the entire time. Now, the other common theme of our work in DRC and in all of our 17 country programs is adaptation. So as we have been building the plane as we fly it, as we all have been doing, we've realized that we have to adapt and learn all the time, every day, every week, every month. And so today what I'll be talking about is how we've dealt with some of the challenges faced in COVID vaccination data and how we are supporting the government of DRC to adapt and think about other options and think about what works for various contexts, even within the country of DRC. And so we're looking forward to sharing our experiences related to strengthening COVID vaccination data quality and use today, and can't wait to hear what the other panelists have to say.
Awesome. Thank you, Jessica. Hassan, please.
Yeah, thanks, and good morning, everyone. Good evening for some of you who are online, probably especially from the region I'm coming from. So yeah, I lead the Digital Square Initiative in Anglophone African region, and part of our role with the USAID, the CN18 grant, is to really understand, how the digital health solution really plays an important role in the COVID vaccination. And also, what are the challenges? And as part of that, we are tasked to understand what are the root cause of some of the challenges that I was seeing today in the space of digital health for COVID vaccination. So our role in Tanzania, Senegal, and Kenya is to really assess the root cause of why we have so much backlog on COVID vaccination. Probably most of you might know in your respective country that with the COVID vaccination, country introduced new solutions. Some of them really enhance the existing solution to really respond to the COVID pandemic. And as part of that, we are seeing countries struggling with a lot of backlog. And backlog means that there are a lot of reported data on the paper-based solution that if you want to cross-check and see how much that is reflected in the digital solution for the value of digital solutions, there are still like 40-50% that are gap between what country are actually reporting and what actually can, be available in the digital solutions that are being implemented. So part of our support is to, go deep into detailed understanding why that gap, why there is so much backlog, and what are we learning from it to make sure that we're informing the existing routine health services when it comes to digital solution, but also coming then, the pandemic, we do have a basis on how do we address it in more systematic and sustainable way so that we don't go back to have another 40%, 50% backlog that are currently hitting us with the COVID vaccination. So as Joy mentioned, we still a work in progress, but we are seeing some, results that we are happy to share with you guys and, explore more. Thank you.
Thanks, Hassan. Stephanie?
Thanks, Joy. Good morning, everyone. I'm Stephanie Watson-Grant. I work for GSI, and I serve as the Deputy Director for the Country Health Information Systems and Data Use Program. So USAID designed CHISU, as we refer to it, to support governments across the world so that they can have access to quality data that's connected through interoperable sources, and that these data are made available to stakeholders within the health system, stakeholders outside of the health system, so that they can make decisions that serve the populations within their geographies. We work in Asia, we work in Latin America, Africa, Europe, in key areas of health information system strengthening, including health information system leadership and governance, systems and software, data quality and use, and importantly, we work with and support local entities so that they can become the sustainability arm of any initiative that is done in those countries. So I think we all remember that when we all began to travel a few months in the COVID pandemic, you had to present a negative COVID test to an airline or some sort of travel authority. And that meant you needed to find somewhere to take the test, you had to conduct the test, you had to get the result, you had to get the paperwork. It seems such a simple thing now, but back then, all these systems had to come into play for that to happen. So in the work that we've been doing in Burkina Faso, when we started, the Minister of Health had already declared that the DHIS2, which is a global public good, developed through USAID, another USAID investment on the measure evaluation, that this should be the system to collect data. So this system was already collecting human and zoonotic diseases, and he then declared that this should be the system to collect COVID data. And he did this after it became clear that there were multiple applications and Excel spreadsheets that were not integrated and were really making data quality problematic. These different sources were not allowing the Ministry of Health to see the status of the pandemic in real time or as near to real time as possible. Dr. Gwande described some of the work that we've been doing in Burkina Faso in his opening remarks, but we worked with the Ministry of Health and other stakeholders to connect DHIS2-based information system to lab systems. We added software so that a traveler could schedule an appointment, pay for their tests, get their results. And then when vaccines became available in Burkina, the vaccine tracking system was added to this. We also work in Mali, and similar challenge in Mali, application proliferation that hindered really a holistic view of the pandemic in the country. And so we've been working with the Ministry of Health. We facilitated stakeholder discussion, which resulted in the agreement that COVID tracker developed by WHO would be used by all stakeholders. So in May, there was about 10% of the COVID surveillance data, the cases, the contact tracing type data, that was available in a tracker. And by the end of September, nearly all the data that needed to be in the tracker was in the tracker. In Indonesia, the challenge, again, is data fragmentation. And we're working closely with the Ministry of Health and have initiated the development of new functionalities to an existing dashboard. This will allow for village and household level data analysis to help locate individuals. And these new functionalities will also improve the availability of population data for coverage mapping and resource allocation. We're also working in a few more countries, Ghana, Haiti, Namibia, and 8 countries in the East and Southern Caribbean. And so there is quite a lot to learn from just the types of countries and the context in which these activities are being done. So this means that we'll be able to learn from countries like St. Kitts and Nevis with their population of 50,000 and Indonesia with their population of 275 million. But before I close, I just wanted to say a few words about these small countries, these smaller countries in the East and Southern Caribbean where we're just starting to work. So these countries, they don't have separate systems for COVID. They have small systems, They have integrated systems in their health system. So we have this wonderful opportunity of when we are working with these countries to strengthen their COVID-related data systems, that it will have an effect on their entire system. I'll stop there. Thank you very much.
Great. Thanks, Stephanie. Liziam, over to you.
Good morning, everyone. Lician Valladares, Country Director for DataFi in representation of Palladium. As I was listening to the opening remarks, it came something very strong to me, and it's the importance of people, and the importance that people make in decision-making and using of digital tools for decision-making. So having said this is, I think, one of the presentations in which I'm not going to be talking a lot about digital solutions, but how to develop skills or upskilling the capacity of health staff for decision-making. So DataFi is a mechanism that is working in several countries in the world, but the work that I'm going to be talking about is in Central America, in Honduras. So for this, we had in Honduras several systems. We have a DHIS2, we have a health surveillance systems developed by PAHO. We had several solutions, but we were not making any decisions. So what was important in this was developing situation rooms, but not the usual ones that were in place by epidemiological staff, but situation rooms that can incorporate other actors such as planning units, logistic units, communication units, to make more enrich the decision making. So DataFi implemented 2 situation rooms in 2 of the main cities in the country that accounted for the highest rate of COVID-19. And then it was decided by the government to implement a national situation room to overview and to take lessons learned and best practices from these situation rooms. So at this point, we have had some very good outputs or outcomes from the process. We have been able to deploy vaccines rapidly. We have been able to assess on the highest of increase in positive rates, deploying services in communities at health facilities, but at larger hospitals. So it's interesting, like how digital solutions can be implemented when you have people committed that own the process, that own the system, and that we are strengthening the governance. And that is what we are trying to do, is propose an inclusive process that incorporate representatives from the countries, epidemiological, surveillance, and other key units for the Ministry of Health to ensure that actions are not also analyzed, but decisions are made and action plans are being implemented and then evaluated and monitored and then provided some input for increasing the capacity in the country. Thank you.
Great. Thank you all for that overview of the work that we'll be talking about today. I'm really excited to hear the learnings that you are gaining from this work. So I will now turn to my first question, which we will be receiving a response by video. The question is, was the digital tool selected to implement the COVID-19 response appropriate given the local contexts, such as the context of the existing digital health ecosystem and architecture in the country? And how might the intervention differ in the context of routine immunization?
The Democratic Republic of Congo followed the recommendation of WHO and select DHS2 tracker as an electronic immunization registry to record and manage client-level COVID vaccination data. DHS2 tracker had been used previously in DRC, but on a smaller scale in the context of the Ebola outbreak. That said, it was a very ambitious plan to use it on a large scale because it is a tool that requires a lot of resources. Hardware such as tablet or mobile phone, enough staff to enter each client data, finances to implement training and supportive supervision, etc. This is in a country where the rate of internet coverage is low, not to mention electricity. Another major challenge is our context is that the majority of vaccination staff are not being paid, which is leading them to be demotivated and not interested in using a new data entry application. We try to run before all things. Hence, it was not adopted easily by vaccination teams, and to this day, a small proportion of vaccination data is entered in tracker. We noticed that some facilities with more resources, such as private facilities, were able to use it more effectively. But in the majority of public vaccination sites, it was very challenging. Another challenge was that it did not align with existing workflow that vaccination staff were used to. The system that has proven itself in the country is the aggregated DSS2, which is the same system used for routine immunization.
Thank you, Dr. Godefroy. My next question is for you, Stephanie. What are some of the key lessons CHISU is learning from the implementation of COVID-19 support in the countries you mentioned?
Thanks, Joy. We're, of course, learning quite a bit, but I'll mention 4 things. The first thing we're learning is that in emergency situations, with all this uncertainty that come with these situations, people go with what they know and what they're comfortable with. And in many cases, that has meant an Excel spreadsheet. And as the pandemic evolved, there's a greater need to consolidate all of these data from all of these different Excel spreadsheets so that we can view the pandemic and the response in a holistic way. So when the next global pandemic happens, or health emergency, because it will, how can we ensure that not only are the appropriate information systems in place, but that people are familiar with them, they're comfortable with them, so it will be their first point that they go to instead of an Excel spreadsheet, which is an excellent tool, I should add as well. The second thing we're learning is that the health information system fundamentals are needed for optimal management of COVID-19 data. In many of the countries that we are supporting, they're still grappling with HIS leadership and governance issues. They are grappling with managing their systems, expanding their systems, deploying their systems, and the software that are supporting these systems. The quality of the data are still a challenge for most countries. So our challenge is how to support these countries with improving their ability to manage their the COVID-19 pandemic and the pandemics to come, while contributing to health information system strengthening. The third thing that we're learning is data management and ownership is fragmented. So when we go into these countries, we're finding that the units that are responsible for COVID are often different from the units that manage the health information system. So we've had to spend time figuring out what these different units are, what the data are, where is it, what is available, who manages it. So enabling integrated COVID data management includes navigating these many units and facilitating agreements on management and access and different processes. And then the fourth and final point I want to mention is that we're finding that there are different levels of quality of the data in supply chain and vaccination data. The data, and of course, these are data that are managed by different units. So we're finding generally a pretty solid handle on the supply chain data. That's the procurement and the distribution. But tracking and monitoring the jabs in the arms really requires a bit more attention. The challenge, therefore, is to really inculcate the importance of proper data collection and at the program implementation level during campaigns so that the data become available for decision making. Thank you.
Great, thanks so much, Stephanie. Hassan, for you. You mentioned that you are working on data backlogs. Could you elaborate a little bit more on what data backlogs are and why it's important to understand their root causes? And how can understanding the root causes of COVID-19 data backlogs, how can it inform the design of digital and data processes beyond COVID-19 vaccination?
Thanks. Yeah. So I think Stefan mentioned a very good, and I think I would say a more typical way that we are seeing downstream. You know, the Excel sheet, the paper tool, you know, the exercise book as, you know, a tool, default tool when it comes to, you know, data, especially, you know, when, you know, there's a lot of political push and attention to the data that is needed. So, and again, I think COVID-19 pandemic, you know, it gave us a lesson that we really need to track in a very better way the longitudinal data in real time, and most important, the accurate data that we need to really inform the health intervention, you know, how we respond to COVID, which are the populations suffering the most, and how are we targeting them with the relevant messaging, relevant, you know, intervention to make sure they are all vaccinated. So many countries respond differently. Some of them, you know, as you know, I've heard from DRC, they followed the WHO recommendation, they adopted the COVID tracker. Some of them said, well, we have some existing system. We don't need to develop any new system, right? The likes of Kenya, I'll say, they are using the Chanjo KE system as their routine COVID vaccination system. And then, as I've said earlier, what we're saying is that, okay, they respond differently than what is an output from this digital system. So when we compare the official reported data, the aggregate data, and what is actually in the digital health systems, there are a huge gap, I would say 40, 50%, you know. So if a country is in the aggregate level, say we have like 20 million vaccination, actually when you go into their existing digital solution, probably 10 million or less. And then that's defy the whole value of why are we using digital solution, because there is a real purpose of why we're embarking on digital health transformation, because of, you know, the value the digital health solution brings into the space. You know, the ability to, you know, track the defaulter in a more easy way, the, you know, surveillance pieces, you know, from within the country to region and global, knowing who is vaccinated by which batch number, whether they've completed the vaccination or not, and, you know, do the risk mapping of the future infection. So by having half of the data in the digital space, we are really not making a lot of value to the digital health solution that we are deploying. So the backlog thing is that we have so much data that down there in the paper-based register, probably the Excel. But when we now want to analyze and see the trend and see who are the risk population and how are we better addressing their needs, it becomes an issue because we don't have complete data that we need to really inform our intervention. And that's become an issue, and that's the backlog that we're speaking. And it's very expensive to really clear the backlog in another sense. So understanding what are the root cause of this backlog, it become a key, not from just programmatic standpoint in terms of, you know, having complete data to inform a decision, but also from investment standpoint. We've put a lot of resources in COVID vaccination and information system, and still need to add more money to make sure data get into this into the system. And that's become a tricky situation. And so the root cause analysis is meant to tell us more in terms of how are we going to avoid the similar fate, you know. Joy, you spoke about strengthening the resilience of health system. And the root cause is meant to tell us more about how are we strengthening the health information system to be more resilient to, you know, future pandemic. And this we're looking from a different angle. Normally we defer to technology as probably one of the core problem, But again, the root cause is meant to address the holistic approach, looking into the technology, looking into the infrastructure, the capacity, the HR sizing, the business process, and actually the core technology from the design standpoint. So having that information will not only inform COVID vaccination, because digital solutions are not just for COVID, they are for every diseases. And the thing or the problem we are seeing, the challenge we are seeing in the COVID vaccination, we're experiencing them across all other vertical diseases when it comes to a digital solution. I'll give an example. We've been deploying the electronic immunization registry in, I'll speak in Kenya, Senegal, and we are seeing, post-deployment, the uptake goes down. So it's a high time to understand why we normally have the peak times, and after some time things start to slow down, and then we are not really making a full use of the information system. So the application is basically, cut across the entire health system. But I think COVID gave us a starting point, and then how we are building our health information system to be able to respond to any future pandemic, and as well, the existing routine health systems that are implemented across the different countries. Yeah.
Thanks, Hassan. Lysium, question for you. So as you have worked to implement these situation rooms, how have quality improvement processes been incorporated in the data use strategy? What tools have been used in capacity development? And also, how is the capacity developed? Are there formal processes, follow-up, or any kind of coaching involved?
Thank you, Joy. I would like to go briefly to what quality improvement is in three small aspects. And one is timeliness, the other one is relevance, and the other one is pertinence. So it is important that we have data quality, but we include quality processes, because the data has to be timely, in real time. It has to be pertinent for decision making. So in this sense, we have designed a data use strategy based on our experience on HIV in Africa. But this kind of quality improvement or in the process needs to be also gender sensitive. And as we have heard before, age sensitive, and so many sensitives that can build from responsive for a pandemic to an overall health information system. So for this, the situation rooms have incorporated the quality processes that include analysis, action, implementation, monitoring, evaluation, and then repeat. These processes have supported case management for vaccine coverage, and also to identify gaps and enable decision makers to understand these existing underlying issues that my colleagues have mentioned before, to collect and to implement digital systems for not only for the pandemic response, but to work to strengthening the health system moving forward. For the analysis action plans that we implement, we have designed this process that we include formal training in the data use strategy, but we are also upskilling staff for digital use, and we are also strengthening their capacity in soft skills. It's not only important that we can analyze the data, that we can know the data, but it's also important that we have the skills to advocate that data for decision makers. And that we have seen that when we are working with the staff at health facilities, probably they know their data, they know their numbers, but they lack the skills to go to the upper management to make the decisions made, to have that advocacy. So we are trying, and we are supporting those soft skills also for communicating purposes, for coordinating. There is always, when we talk about gender, we use this a lot, like having the regular models when men talk more, and we have, like in Latin America, there might be like 20 women, but when there is one man there, he's the one who talks. But that's, also one thing that we are trying to build, this gender sensitive and this approach for communicating when people have a voice and they can voice their concerns and move forward the actions. So we have these formal trainings in data use, but we have also have coaching and mentoring, and we have implemented routinary data quality assessments just to add and to have more information to support a more integrated health information system. The situation rooms implemented in Honduras have enabled a stronger coordination and stewardship of the pandemic response from the government and moving forward to other health issues that may arise. We know that the process needs to be aligned, and we are aligning to the digital agenda in Honduras, to the Gobierno Digital, and also other actions implemented by the World Bank and the IDB. We are trying to have an aligned approach so we can move forward. We know that there is a long wait for this, but these actions need to be implemented, and now we have placed in the Situation Room the basis for the relevance and implementation of a digital agenda that has been established in the country. Thank you, Joy.
Great. Thanks so much, Liziam. Jessica, Liziam just talked to us about their quality improvement processes. What are you as a project doing to improve the quality and use of COVID-19 vaccination data in the DRC?
Thank you. Yeah, it's been great to hear all of the responses from the other panelists this morning. There's so many commonalities, both in terms of challenges and then in terms of how we're starting to think about the appropriate solutions during this very complex time. So as you heard my colleague Dr. Godet say, that the history of deciding to, yes, take the recommendation to use DHIS2 tracker as their electronic immunization registry, and as Hassan mentioned, there was a realization that the backlogs were frankly too large to address sustainable. And so the initial thought in DRC and in many countries was, well, we can back-enter backlogged data, client-level data, by hiring data entry clerks, and we'll take, whether that data lives in an Excel spreadsheet, on paper records, in a Google form, we'll take those all, and we'll back-enter them into the tracker system so that each client has their individual level record. But it was, as we started to think about that more, and as stakeholders in DRC thought about that more, they did start to wonder whether it was sustainable and appropriate. And so we engaged in some user-centered design, in some co-creation work to talk to healthcare workers, to talk to the folks who were entering data at the vaccination site, to understand what their needs and challenges were. And at the same time, we started to have conversations with the immunization program at the national and provincial levels to say, what are we using the individual level data for? And that was a really, really big question. And so as Hassan pointed out, there are some amazing important uses of individual level immunization data from EIRs, but in this particular context, we weren't sure if all of the resources required to make that work was really worth it. And so we started with other partners talking to the immunization program about, well, let's look at routine immunization where the use of regular DHIS2 seems to be working. So, we have workflows that seem to work. Folks enter the aggregate tallies of number of people vaccinated. That's sent up. It's entered into DHIS2. The data become available for people to see in one place. What if we started to try that in one province? So I know probably to this room it seems like we're going backwards. But as Dr. Godet said, we had tried to go forward maybe too quickly. And so now we're thinking about what is working from routine immunization. What if we try that for COVID vaccination? And then at the same time, start investing in the governance, the architecture, the infrastructure necessary to eventually get DRC towards an individual level EIR system. So at the same time that we're doing that work, and we've started and it seems to be working out really well, we're also investing in the people, in investing in better supportive supervision, better coaching of folks who are entering the data and using the data at all levels. We're investing in better situation rooms, just like DataFi, at various different levels to look at and discuss the data and the information regularly. We're using some of the approaches that we've used in routine immunization, like peer learning networks over WhatsApp, so that data clerks and data managers can discuss with each other what their challenges are to either using the systems or using the data in the systems to make decisions. And we hope that through these, not only, as others have said, not only will we strengthen COVID vaccination data, but we will also strengthen routine immunization data and just all of primary healthcare data, because COVID vaccines are now moving very much to be integrated within other essential health services, under other primary healthcare services. And so by strengthening it holistically, the whole information system, we hope that that's a more sustainable investment moving forward. Thanks.
Great, thanks so much, Jessica. Stephanie, speaking of transitioning to more routine, what do you think are some of the areas of particular focus for support as countries start to transition their COVID-19 responses from emergency to routine epidemic-prone diseases?
Thank you, Joy. And there are lots of themes that have already come out. The first area of focus is investing in skills. We've heard that a couple of times here on this panel. COVID provided us with some very difficult but useful lessons about the skills that are required to respond. Some of these skills have been utilized during this pandemic are highly specialized and very expensive, especially those related to analytics and communication. So as countries transition from an emergency response to a more routine response, these skills will still be needed. And so there needs to be a plan in place of how to retain these skills and how to use these skills for other health areas. The second area of focus is establishing or disseminating standards for the development of information systems. The challenge of system proliferation and data fragmentation can be met when there are known data exchange standards. These standards will facilitate system interoperability, which will allow COVID-19 and other data to be managed as they are managed for routine epidemic-prone diseases. Almost as important as these data exchange standards is changing behavior. And behavior where those who are charged with management immediately reach for their Excel spreadsheets, their exercise books, a piece of paper. These are needed things when you're starting in an emergency, but they're less secure. They have less data security than the information systems. And as the pandemic matures, the data needs will evolve, as we have all experienced. And the challenge will be to facilitate change management processes that will separate people from their beloved spreadsheets and exercise books. The third area of focus, following from the second, is systems interoperability and data integration. Understanding what data exists in what systems, determining whether the existing systems are ready to interoperate with other systems, or if additional steps need to be taken to realize this interoperability. Interoperability between these systems can reduce data management burden. It can allow for a more comprehensive picture of these epidemic-prone diseases, and it would provide insights that usually would not be observed if the data were siloed. The fourth area of focus is investing in planning for health emergencies, while continuing to implement and maintain these routine systems. So this is different from investing in the expansion of the emergency information systems. So investing in information systems that will be phased out or have no further application beyond the emergency situation is not a good use of limited resources. So importantly, as we engage in these health emergency planning exercises, it's important to acknowledge who is at the table, as well as who is not at the table. COVID-19 impacted health systems as well as individuals. And at the individual level, the impact was different for different people. So we must be deliberate about including voices of people, such as mothers, who were hugely impacted by COVID-19, in health emergency planning processes. So summarizing, focus on skills, standards for developing information systems, systems interoperability and data integration, and planning for equitable responses to health emergencies. Thank you.
Thanks, Stephanie. Really interesting. Hassan, tell us a little bit more about how Digital Square is diagnosing the root causes of the data backlogs and what you've learned so far.
Thanks. Yeah. So from a methodology standpoint, what we're really doing with the country, in the 3 countries, is really we have like 3 processes. One is we do surveys, and this is speaking to what Stefan saying is we're doing it across the health system. Looking at the national level, who are the core player, key player, subnational level health facility to point where reaching the frontline healthcare worker. We're not talking to mothers yet, but I think, we are looking at it from more of a supply side of it. So we do surveys across all levels, is mainly to understand the behavioral aspect, the organizational aspect that are limiting the use of these tools. And also understanding from the existing guidelines, policies, what are things there that we can capitalize or really change to make sure that we are, optimizing the adoption of the digital solution for COVID vaccination. So that's the first approach we're taking. The second approach, we do some observational study, and this is mainly at the point of care, because sometimes, your frontline healthcare worker are too swamped into their challenge to realize that there are challenges. You're too deep into it to, it become a normal rather than a challenge, but observing it from a neutral standpoint, you can really see the differences between how the solution are designed against what are the business processes and what are the pain points that are, the digital health solution can really be able to address. So we do also those observation study across all the 3 countries that we're doing the RSA. And the third layer of it is now we're doing a deep dive into the technical aspect of the design and the configuration of this solution. More to understand, are we really designed for scale? Because, from digital principle of digital health development, we normally say design for scale, right? So how much we translate that into the solution itself? Are they designed well to scale? If not, then how are we informing those design? So there are 3 aspects, I would say. So there's that organization behavior that we are looking at. There is observation to really see the challenge from a neutral standpoint, and the technical assessment of the solution themselves in terms of design configuration to be able to be impactful. So while the root cause analysis is ongoing, we are seeing some of the results, and I'll quickly look into the processes. When we do the observation downstream, we kind of look in terms of, okay, what is the time? What time does it take to register and vaccinate one person? And with everything in between it, from using the Excel paper there, introducing a digital solution in the space and actually doing the job. So from our time motion study, it takes about 8 to 10 minutes. And you can imagine only about 1.5 minutes or 2 that is actually used for the jabbing. The rest of it is mainly related to data collection, doing the register, doing the home card, and then and strangely enough, when you compare the existing paper base with the digital solution, it's like 4 minutes each, doing the paper 4 minutes and then doing another 4 minutes for the digital and doing the data entry in the system. And the question is, do we really need to do both, it's for, we can debate about it. And I think the other important piece is the whole essence of doing digitalization is really to improve efficiencies, especially during the data collection, right? So why are we still within the 4 minutes as to the existing paper-based? So the question for the, the software people here is, what can we do to optimize the process so that we end up with a minute of data doing the registration rather than doing the 4 minutes plus 4 minutes plus 2 minutes. So that's up for you guys to think through how we do that. So that's an interesting aspect to see, if we're doing one person registration and vaccination in 10 minutes, and the data we have is that it tells us that about 75% of the COVID vaccination comes from a campaign. So you can imagine why we have backlog then. We have, during campaign, it's massive, everyone is there's a lot of queue, and still you need to do 10 minutes. No, it becomes very inefficient. So at some point, they have to go back to the basics, Excel, and then we figure out how we get into the digital solution, the system that we're using. So that's what we're seeing, And speaking of, the capacity of the people, so our preliminary analysis there show that we have a facility where there is only one person, the dispensaries. So you can imagine a facility with that one person, and then we're introducing tool that will take 10 minutes of their time, 8 minutes of their time just doing the data collection, only a minute or two to do the actual job. So what normally they do is, they devote back to the basics, they do the vaccination and figure out how we can get, you guys, we're gonna get their data at some point. So then the question is, how now do we address this kind of situation, from a digital standpoint? It speaks to, the integrated approach, it speaks to comprehensive, because you only have one person who does everything, and we wouldn't want to, do 3 tools that, capture different stuff. And again, we don't want to go back to a point where they use 4 minutes to just do data entry and, not doing the actual job that they are paid for. So that's what we're seeing. And then again, what we came to realize is about 1/3 of these healthcare workers, they are not really properly trained to use this digital solution. So again, what do you expect? It's backlog. You don't understand how to use the solution, then you go back to Excel, things, become easy. So that's one aspect. And then when we look into the technology aspect of it, is that about 50% of the people we've talked to say that there is a performance challenges within the existing system. And this is, the COVID system that are in the 3 countries. There's DHS2 tracker in Tanzania, Senegal, and Kenya. So the performance issue. So again, looking at it from the context of one person, again, you have a performance challenge with the system. The response time, you enter one detail, you have to wait 3 minutes for this to respond, become difficult. So again, it all compiled to the backlog thing. And part of the challenge is also internet, and strangely enough, it's not about availability of internet. It's about actually who is paying for that. What we've realized or see from the data is that the availability is not really a case. Rather, they have to use their own money to pay for the internet access. Again, for a solution that is web-based, paying your own cash, it becomes very inconvenient and then difficult to really work in that context. So I'll stop there. It's in the interest of time, but I think it's very exciting to see the results, and then how are we applying these results to make sure we don't go back to where we are right now. Thanks, Joy.
Yeah, thanks, Hassan. Super interesting and thought-provoking, and I even forgot to time keep, so thanks for stopping yourself. Lysium, our last question is for you. How has the experience of establishing these situation rooms how is it enabling digital health? And what are the bigger issues in the country to help develop and adapt digital tools?
Okay, thank you. It is very important to that many of the things that you have been saying and that we heard the remarks are based in what we are assessing today, what I'm going to say right now. Even if the approach is very comprehensive, implementing situation rooms and identifying gaps and providing solutions, we've talked about DHS, we've talked about Excel spreadsheets, we've talked about several things, but what we really need to talk about a little bit more is about the people and their capacities, and how at some point, even if now we are in a digital era, everything is more digital, health has not moved forward as fast, but is also a threat to people. When we talk about governments, when we have like 90% or 70% of some populations are government employees and they depend on jobs that are related to data gathering, developing those Excel spreadsheets. So that comes to this bigger issue that I will be talking about is how to improve and have change management, communication for behavioral change. We did use that a long time ago for some other health situation, but right now we have to go back and to bring this and think how people learn, how people think, and how they can shift their positions, their jobs, because that is what has been one of the main challenges. They have the tools, but they don't want to use them, not because they cannot, it's because they are afraid of losing their jobs. So that is one of the issues that we have seen in the country. Other issues are related as well to staff rotation. We keep training people and then people go to a different job, so we hope that those skills are implemented in other areas. But we are continuing like upskilling staff. Some other issues are related to the connectivity issues. We talk about having computers, having the systems, but we don't talk about a lot about the internet connection, where it's possible, where it's cheap. So we need to think about a lot about connectivity and creating these public-private partnerships that enable governments to have the capacity to interoperate these platforms. We do also need to address the fact that the legislation in the country is not very supportive of digital health. That is other thing. We talk about and this is a word I'm going to say in Spanish, la tiranía del papel. So the paper is a tyrant because every single legal framework is designed to keep paper, to keep the paper forms, to file the paper forms. So people are forced to continue to support this. And we have been supporting the smart paper technologies as well in coordination with the IDB and the World Bank, but it's always the legal framework does not allow to move forward. Even for the private public sector partnership, it is always a challenge. Some of the other things, and I think this is the last one that I'm going to say, and probably for some it's not going to be a nice one, but I think that it needs to be said, is alignment and governance, but alignment of donors. Because every other time that a pandemic comes or an issue comes, it's like, I have the system, my system is better, mine has this, mine has that, but we have to be very understanding and very cooperate more. Like if I said, someone said that when we're talking about our project, it's called DataFi, but at some point someone said as data if. And I was like, data if what? Yeah. So if we cooperate, if we coordinate, if we do what we really need to do and see the bigger picture, because now was COVID, back then was HIV, but it will be a lot more things that we need to have a health system that is comprehensive, that sees everything, because we are not one thing. We are just one human being with several problems. And as we had our colleague in our former panel that she was talking about aging and stuff. We don't really talk a lot about women's issues, but we need to. So this has to be integrated and move forward if we need to have a digital agenda, that we have electronic medical records, that we have people who are entering the data and not saying, I'm a doctor, this is not my job. That's the job of the nurse. So it has to be more comprehensive. And I think those are the issues, but as donors, cooperation, we need to align and support the governance in the countries. It's not our agenda, it's the country's agenda. And so thank you very much.
Thank you. Great. Thanks so much, Lysium. Oh, well, yeah, you should get that. So I want to thank you all for taking the time to speak with us today. I think what has been very interesting to me to hear is that even though these studies are in very early stages, really, there are some themes that are starting to come out that are, across the board. And my takeaway from this panel, which I will note, I think we all know this already, but it's not just about the technology, right? It's also about the people and the governance and just having the data doesn't mean that you know how to use it and all of that. And, and COVID has provided us with a very unique opportunity to conduct focused studies with focused pots of money that were, meant to deal with this crisis. But how can we learn from what we're doing now to apply it more broadly to, the broader health system and, to primary health care? And I think, it's very interesting to be dealing with a crisis 4 years after Ebola and asking ourselves, what have we learned from, since then, and how have we matured, and what haven't we learned, and what are the conversations that we're still having, half a decade later. And, there's still a lot of things that we haven't learned, and we're continuing to talk about. So I'm really excited to see the results from the studies once they are completed. We are looking forward to maybe hearing about them at next year's Global Digital Health Forum. And in the meantime, I just want to thank the panelists for being incredibly efficient. We started late and are ending early, so that's amazing. So thank you all. We really appreciate your time, and thanks everyone for spending your time with us.